Welcome, welcome everyone, and happy Thursday Night Live, even though we are recording this for members early. So if you're watching us live, thank you for being an Airway Circle member and allowing us to bring this huge resource for all of our airway professionals. Every Thursday night, we do a webinar. We have over 200 of them already recorded for you. So if you'd like to dive deeper, we would welcome you into the membership. However, you can invite your colleagues that are just starting to get into this field, want to learn a little bit more, invite them on Thursdays. It's free for everybody to watch live. So thank you for being here. We have a very special guest with us today. I'm going to go ahead and introduce her. Dr. Susana Falardo, a globally recognized expert in dental sleep medicine, orthodontics, and myofunctional therapy. She holds an European PhD in Pediatric Dentistry and Orthodontics. She's a diplomate of the European Academy of Dental Sleep Medicine and an International Certificant of the American Board of Dental Sleep Medicine. Currently, she serves as president of the EADSM and teaches at the Catholic Medical School in Portugal, where she also coordinates a postgraduate sleep medicine program. The topic today is the impact of oropharyngeal exercises on OSA patients, one of my favorites. So thank you so much for being here. Did I miss anything?
No, it was just great. Thank you so much, Renata, for the sweet introduction. It's a really pleasure to be here tonight. Well, it's evening. It's not night yet here in Lisbon. It's evening, but well, I'm very happy to share the topic with all of you.
Well, thank you so much. The stage is yours. You can try to share your screen.
Okay, let's see then.
I'm going to go live on Facebook just for a little bit.
Okay.
Give everybody a taste of what they're missing. There he goes.
Just put here. I don't know if I'm gonna put on the. Is this okay for you guys?
That is absolutely perfect.
Okay, so yeah. So again, thank you for the Airway Circle for the invitation. For the next, I think, 1 hour, something like that, I will talk about the impact of oropharyngeal exercise on OSA patients. As Renata introduced me, I have, well, a large, I would say, a large knowledge on myofunctional therapy. I did my master's science on myofunctional therapy on OSA pediatric patients. So I'm going to share what I know and some clinical cases at the end of my presentation as well. So I have nothing to declare related to this presentation or any other topic on my life. So I'm going to skip this one because Renata already introduced me so well. So thank you again. And well, through this hour, I'm going to run all these topics. So a little introduction, I'll review some topics here and some knowledge, just friendly remind, because I think we all know about this, but it's always great to remember. Craniofacial growth, the functions, the anatomy, the muscles, and also talk a little bit about the fascias, which are, as you know, super important for the myofunctional exercise and for the success of the therapy, of course. Reviewing some concepts on physiopathology of obstructive sleep apnea, epidemiology, diagnose, talking about some risk factors, guidelines, and then I'm going to share what we do here in Portugal at my clinic on the anamnesis and on the clinical history of the patients. I'm going to review some aspects of the literature, also the tools that I'm going to share with you and the protocol that we use. And I have 2 clinical cases to share, and I will finish with a take-home message, of course. So I think we all know that OSA, obstructive sleep apnea, it's a chronic disease, but has a high severity of mortality and morbidity. And does not matter if we are talking about adults or children, so it's the same. But in children also presents a negative impact on cognitive functions, behavior, and school performance. What we know about the craniofacial is that during the 5 million years, we as humans and our skeletal patterns reveals significantly changes, not only on all overall our skeletal, but mainly at the facial level. So at the light of the current knowledge, this evolution, it was not only about the posture, but also contributes to the appearance of different partners of the mandibular growth. And that, as you know, we all know that bipedism and vertical posture may have caused a verticalization of the skull. And this has a huge impact because it was not only the skeleton, it was not only the bones that grow on a different pattern, but also the soft tissues around it, so the muscles. And we had quite a change, mainly at the level of the ion bone. And we also start to have and developed with a longer hairway and the less direct passage for the air. And that, of course, favoring the appearance of the obstructive sleep apnea. But seeing together this image, we can start to realize what were really the difference between or during our evolution for all these years. So we have shortened palatal. We also have shortening the bones of the ethmoids and the jaw, less angulation between the oral cavity and the skull base. So we have a more anteriorized foramen magnum. We posterized the tongue into the pharynx. We lost the overlap between the uvula and the epiglottis, and that is a huge. That I think it's a major. It was one of the major patterns of evolution of our species, because this favors the tongue going back into the oropharynx, and in some individuals favoring the respiratory events. So we had a lot of situations here happening at the same time with all this evolution. And of course, this all contributes, well, we speak, that's true. We have vocal cords, but perhaps this is a very high price to pay, for our evolution. Now, just a friendly reminder, because we must know this, but some of us will learn these basics at the basics of our undergraduation during school, during college or university, but just to friendly remind what are the most important muscles that has a direct impact on the upper airway. So if you follow the arrows and the colors of the arrows, you will find also the description on the slide on your left. And this means that we have, well, to focus mainly on these muscles and their function, but mainly the genioglossus, because that is one of the major muscles that we will talk about during this lesson, and also all the exercise, mainly the majority of exercise are very direct to the tongue and also to the praxis, and balance the muscle tonus. Well, but moving on. So what we know is that the changes that occurs during sleep, and mainly they are related to the reduction of the muscle tone, and of course the collapse of the pharynx in the retropalatal and in the retrolingual regions. So these are the two main regions that the majority of the respiratory events occurs, even though there are some other respiratory events that can occur on the level of the hypopharynx. That ones are more difficult to solve with exercise. I would say even with mandible advanced device, they are not recognized as such for therapy. But we know also that the increased activity of the pharyngeal muscles reduce the collapse of the upper airway. So again, we already know that we have to work a lot these muscles, or try to work a lot the muscles of the retropalatal in the area of the pharyngeal, of the oropharynx, in order to avoid the collapse and to allow the passage of the air. And we also know, in addition, that the poor muscle response leads us to the hypercapnia and hypoxia, and the negative pressure has been pointed out as one of the known anatomical phenotypes as a possible predictor of apneas. And I will, in a few slides, I will talk about the phenotypes of OSA, just to, to put us on the right spot to understand all that I'm going to share with you. Again, so we are talking about muscles, we are talking about the oropharyngeal muscles, so we need to recall the muscles that are related with the palatal glossal arch. And if you look at the slide on this image on the bottom, you will see that we have an upper airway which is large on healthy patients or healthy individuals. But when we are in presence of OSA patients, we will have a more straight upper airway, and the muscle, the genial glossus, will be one of the most responsibles for the collapse of this upper airway. So I'm going to just run quickly these first slides, but it's also to remind you that we are going to talk a lot on the genial glossus, but we are going to talk a lot on the generality of the muscles of the tongue. And for that, we need to remind that we have the intrinsic muscles and the extrinsic muscles. They are responsible, one, for the shape, and also remind that the intrinsic muscles, they insert, some of them, also, if not the majority of them, they insert in the extrinsic muscles. And these ones are responsible for the movements and the position of the tongue in the oral cavity. And what about the position of each muscle and the proportion of each muscles along the tongue? So again, we need to know this, or at least friendly remind or recall of all this anatomy and the directions of these muscles and the fibers and the density of the fibers, because this will have a huge impact on the exercise that we are going to select to the patients, and also on the results that we are going to have working all the muscles and working all the balance of the tonus of the tongue. And knowing this, we will have more knowledge on what muscles are directly related to some of the movements. For instance, if we want to retract the tongue, we know that the muscles who are capable of this function are the hyoglossus and the styloglossus. So we need to work these two muscles, and we need to prescribe exercise to work these muscles. This means that we are going to work the tongue inside our oral cavity. So if you want to work the protrusion of the tongue, so you know that you have to work the genial glossus and also the posterior, mainly the posterior fibers of the genial glossus. And this, it's very important to know, because if you want to protrude, we are going to do exercise with the tip tongue outside the oral cavity. And again, if you want to work the articulatory muscles, you need to know that they are intrinsic, superior, and inferior longitudinal muscles who are responsible to these movements. So you need to know, in order to move the tip of the tongue up or lower, you need to know the muscles, and we need to identify what type of exercise do you want to prescribe to your patients. And again, not only we are talking about the muscles per se, but we also need to remind that each muscle has different types of fibers. We have, as we all know, the red fibers and the white fibers. Ones are responsible for the isometric, and the other ones are more responsible for the isotonic. So this means that if you are working a certain muscle with a certain exercise, it's not a non-stop exercise. So you need to rest in order to have a good response. So it's the same like going to the gym. You need to do pause between the exercise in order to increase the response and in order to avoid the fatigue of the fibers and the fatigue of the muscle. So there's a lot of literature regarding to this, and what we know, one of the articles that I like a lot to share, it's this Sanders and 2013. He illustrates very well all these movements of the tongue and all these exercises that I have been shown to you. But he emphasized that these muscles, we need to be very careful, because dependingly on the blade or the body or the base of the tongue, we have different types of fibers, different directions of fibers. So we need to intensify more or less the exercise according to this type of the fibers. And these are one of the responsibles for the OSA patients in order to have more tonus or less tonus, and of the tongue to be one of the responsibles, or the genioglossus be one of the responsibles for the obstruction of the upper airway, not allowing the fluid, the permeabilization, and the continued passage of the air. This article shows it's very important. So this was a study made on 17 OSA patients and 11 snorers, And what we could reach from the result, it was that they find that the enzymatic and glycolic activity is higher in the apneic patients than in the snorers, and that type 1 fibers were higher in the genioglossus of the apneic and snorers than the type 2 or type 2A or type 2B that were more found in the apneic patients and not found in the snorers. So this means a lot, because again, if you are going to select the exercise, and if you know this, so you need to be very aware that type 1, they are the red fibers, and type 2, they are the white fibers. So you need to intensify more or less the exercise and the time that you are doing the exercise as well. So it's a huge difference. And the conclusions for this study was that metabolic difference in apneic and snoring are not observed in all the upper airway muscles. So again, it's like doing precise, and we talk about precision medicine and the personalized, individualized medicine. So this is also with what we do here on myofunctional therapy. It's precision myofunctional therapy in order to have more individualized medicine and more direct and personalized exercise for each patient and each muscle per se. So histologically, the conclusion of this article was also very curious, because they shown that there were differences between the genioglossus and the muscles of the uvula that can be one of the implicates, the one that are related to the pathophysiology of the obstructive sleep apnea. We are talking about the muscles, but we should not forget the fascias, because as you know, the fascias are a lot of I call it connective tissue. It's a kind of, I always, when I'm lecturing about the myofunctional therapy, I always use this phrase that it's a kind of glue that puts all the muscles together and allow us to walk without following any one of the muscles. But we need to be very careful with this because mainly they are collagen. So we need sometimes to release the fascias in order to have better movement, in order to have better adherence to the exercise and better compliance of the patients, and also great outcomes with all the exercises that we can prescribe. So sometimes only do the myofunctional therapy, it's not enough. So we need to work together with physiotherapists or osteopathic or kinesiotherapy in order to release the fascias, so we can obtain a good results on the prescription and on the exercises. So remind a little bit about the muscles and the function of the fascias. They have this function to give us all this kind of glue, like I said before, but also it's important that they are also related to the weakness or the stiffness of the muscles, the functions of the muscles. Also, they have a great responsibility on the proprioception and also in the pain perception. So again, we need to be sure that all the fascias, and we have some of them, that provides all this structural support, not only to protect the muscles and the organs, but also to reduce friction. They are released in order to not to transmit pain signals. So this is very important, because if you have, for instance, a trigger point, this is going to be very hard to your patients to collaborate, and you will not have adherence or compliance of your patients for your exercise and for the exercise you are prescribing. So we need to remind that we have layers of fascias, and we need to work some of the layers of the face, of the neck, anterior and posterior neck, in order to have good response on our therapy. And one of the fascias that we need to talk about, because it's now mandatory, even though fashionable, mandatory, the tongue tie surgery, but we need to be very careful when we are prescribing that, because tongue tie, it's part of the visceral anterior fascia. So we are really connected from the head to the toe, but we need to work on these cases on a very tight collaboration with osteopathy or physiotherapy in order to work and to have a good posture, and of course working together with the surgeon or the dentist that are going to perform the tongue tie release, and do a protocol before and after with myofunctional therapy and exercise. So literally, we are linked to the head and toes. And for the ones who do frenectomies and like to evaluate tongue ties, I use this protocol. It might not be the one that you use, but it's the one that we are used to use here at the clinic. And we also do this together with the speech therapists that work with us, because besides I had knowledge on this, I have 2 speech therapists at the clinic working with us, collaborating with us, and also doing the evaluation of the tongue ties. And if you have a doubt, what I can say is that first start with myofunctional therapy. If the tongue does not respond to the exercise, if the tongue will not achieve the posture that you want to achieve, then you might consider for the tongue tie if you have a doubt. Well, if you don't have a doubt, you have to first perform myofunctional therapy and then do the tongue tie release, and then continue with the myofunctional therapy. So there are 2 types of ties, the anterior tie and the posterior tie. And say that the easy part to see and to evaluate is that if it is a posterior tie, when you try to rise the tongue and the floor of the mouth come along, so probably it's a posterior tie. And this one you need to be very careful on the intervention that you are going to realize. Also, don't forget that it's not only about the tongue tie, but sometimes you also need to evaluate the upper and the lower lip tie, because they will be very, they are responsible also for the seal of the lips, also for the primitive movements, and for the balance of the orbicular of the lips as well. So you need to evaluate properly, otherwise you will have a child with difficulties to feed on the speech also. He or she will have some cervical posture alterations, which is not good. And maybe you are contributing to a future mouth breather, which is not good as also. So you need to evaluate very, very well. This is other protocol for the ones who like other protocol than the first that I show. So this is the breast protocol, but again, evaluate very well. If you have doubts, you started with first the myofunctional therapy and then you go for the tongue tie, but never forget that you have to do myofunctional before and after. So I'm not talking about a novel therapy. I'm talking about something that it's settled for decades. So there's a lot of information, there's a lot of scientific evidence base and articles, very good articles. And this is one of the articles that mention exactly the importance of frenectomy and the importance of myofunctional therapy, especially after. But what they show here on the articles, they select 1,030 patients that were affected by ankyglossia with a classification class 2, class 3, according to the clot tongue evaluation, and myofunctional therapy and global posture exercise were performed to all the subjects evaluated. So, and the conclusions were that tongue tie before and after, myofunctional therapy before and after tongue tie release with atmospheric plasma can yield significantly functional improvements, chewing and swallowing, speech and sleep of the child, as reported by the parents. And we need to be very careful when we address and when we read the articles, because there's no, I would say, a linear relationship with tongue ties and sleep, but we know that they are some related, not directly related, but yes, they are somehow related if we think it well, like a chain. So if you think well, and if you do a fluxogram, you will reach the connection between the tongue tie and the sleep, but it's not very, very linear or a direct relationship that you can find there. And what about snoring and obstructive sleep apnea that I'm talking about here? So I think we all know this at this moment. So everybody now talk about snoring, everybody now talk about OSA, but nevertheless, we know that OSA, it's characterized by the current collapse of the pharyngeal airway, so during sleep, of course, and snoring in most of the cases. That does not matter if it is primary or secondary, but in the most of the cases is a combination of a respiratory event, and it is associated with a brief wakening or a sleep arousal, as we know. But now talking about children, what we know from the pathophysiology, pediatrics, OSA, and snoring is that we have, according to David Gozal, we have broadly two types or two factors that can contribute to the physiopathology or are related with the physiopathology. They are the narrowing factors, related to the hypertrophy of the adenoids and the tonsils, so inflammatory response of soft tissues, and obesity. So these are the main factors that can contribute to the narrow of the upper airway. But also we have other collapsible factors. Again, obesity, because as you know, the lateral of the oropharynx, we can have little fat pillows that can also contribute. It is one of the localized zones for the accumulation of fat tissue, and also the base of the tongue. It's also one of the responsibles. And of course, this is like a snowball. So if you are obese, if you have inflammation, you will have more fat on the base of the tongue, on the pillows of the lateral walls of the pharynx, and that will contribute to the collapse of the upper airway, and you are more susceptible to have apneas. As I mentioned at the beginning of my lecture, there are some phenotypes, and it does not matter if you are an adult or if you are a children. So this is a slide that was that is published in the articles of Danny Eckert, and he explained very well these phenotypes. So basically, we have two phenotypes that are identified. So the anatomic phenotypes, who are related with the structure, with the growth of the skeletal, like we saw in the first part of the lecture, and then the no-anatomical factors that are related with the muscle response. So we already know that not was only the skeletal that had some alterations during all the process of our evolution as human beings, but also the soft tissues around also suffer from this evolution, and also the lower arousal threshold, which are the threshold of response to the respiratory events, and also the ventilatory drive or control, which is the high loop gain, that it's also the impact of the response. So what we know is that around 69% of the individuals, they have at least one or more non-anatomical factors. So this means that we need to look to the patients not only regarding to prescribe only a unique solo therapy, but mainly that we need to look to the patients, and perhaps we need to combine several therapies. And of course, one of those are myofunctional therapy and all the exercises that we can prescribe as well. So as I told before, so we more and more often we are talking about precision medicine in order to individualize and to prescribe more direct treatments to patients, so individualized treatments for each patient. Are different persons, so we need to work on that. And if you look there, training is one of the therapies that are prescribed for the poor muscle response. So again, we are not talking about anything abstract. We are talking about a therapy that has a lot of indications and that has a lot of high evidences. So don't forget that we need to deal with a huge number and we need to look for the epidemiology and for the prevalence of the obstructive sleep apnea and snoring in the worldwide population. So we know that around 9 to 50% of men, they can have a high prevalence of snoring. Only 4 to 17% of women report snoring, but the majority of the snorers developed obstructive sleep apnea, and about 80% of this, they are obese. So obesity is one of the risk factors for developing, I would say, respiratory events. And I will include on the respiratory events, I will include the snoring, the upper airway resistance, the hypopneas, the apneas as well. But if we focus only on the obstructive sleep apnea, so the numbers are 3 to 7% on the men's and 2 to 5% on women, but we should not disregard that menopause women have 3 times odds ratios to develop obstructive sleep apnea, and we also have the pregnant women that also are very, very susceptible to develop obstructive sleep apnea as well. The numbers for children, they are not good. So 1 to 4% of the children between 2 and 8 years old can present obstructive sleep apnea. And of course, obesity is one of the risk factors for that. The diagnosis, there are mainly 4 type of sleep exams. So the type 1, it's the classic polysomnography that you have to do on a lab, but it's the gold standard. You can diagnose any kind of sleep disorder. So then the type 2, it's a home sleep test. It's similar to the first one, but it's not recorded. You can do it at home. And the type 3, which is known here in Europe as a cardiorespiratory test, it's a home sleep apnea test. So it's a more simple test that type 2 has less sensors. And the type 4, which are the nocturnal oximeter, it's not for diagnosis. Maybe you can use it to screen your patients or to control the therapies that you are doing. The classification and why we classified apneas and the level of severity, it's also different between the pediatric population and the adult population, as you can see here on the slide. So we have different values for mild in the pediatrics between 1 and 5, and between 1 and 15 for adults. For the moderate in pediatrics, we have between 5 and 10, and for the adults 15 to 30. And for the severity, if you are a child, if your child has more than 10 or 11 events per hour, so it's a severe case. And if you have an adult patient with more than 30, it's a severe patient as well. So be that in mind. And again, the risk factors or the predict factors for all of this, we are talking about obesity, and we are talking about body mass index. But be careful with this, because if your patient is a very athletic patient who like to go to the gym and work out the body every day, maybe he has a high body mass index and he's not obese. So be careful when you are interpreting the results or doing the questionnaires and all the evaluation. So age, like we saw, it's also a risk factor. And then habits like smoking, having some alcohol, then other type of behaviors like late heavy meals, sedatives, and of course obesity, like I said that before. For children, it's the same. So just reviewing a little bit, it's like so the risk factors for pediatric obstructive sleep apnea, with no doubt the first risk factor, it's hypertrophy of the adenoids and the tonsils. This can lead us to a mouth breather, and this mouth breather will have alterations of the growth at the skeletal facial level. We should not disregard the genetic patterns in the obesity or the weight, because some of the children, if they are not obese, they are overweight, and this is a very important aspect right now. Nowadays, it's like a pandemic situation, and it's very well recognized, unfortunately, by the World Health Organization. Now going deep on myofunctional therapy. So like I said, I'm not talking about a nouveau therapy. I'm talking about a therapy that's more than 100 years. It started in 1912. It was introduced by Leisure with the objective to prevent and treat malocclusion through re-education. Can you imagine? So we are still continue talking about this and talking about the importance of myofunctional therapy. It's all there. It's all on the books. We just have to go back and read it. And then continues in the 80s, in the 70s, then in the 80s, where there were established objectives and methods of treatment and behavior reducing habits, parafunctional habits, and also improving patients' aesthetics. And nowadays, in the 21st century, colleagues like Aline Braga, Esther Bianchini, Catarina Camacho, all colleagues from Brazil, because Brazil, it's a very strong country on myofunctional therapy. So they have applying therapy to the treatments of snoring and apnea with a high evidence and a huge success. But exactly what is myofunctional therapy? So we know that seeks to equalize through isometric and isotonic exercise the tonus of the muscles, not only the tongue, but also the soft palate and the facial muscles as well. And this relationship goes back to the fact that structures involved in sleep-related breathing disorders, and we are talking about, of course, apnea, obstructive sleep apnea, and snoring, are neuromuscular units that are object of study and intervention of the myofunctional therapy. And going again to starting just a little bit reviewing here the literature, it's important to mention that in 2023, there was a consensus that was released during the World Sleep Society last time in Rio de Janeiro, and all the colleagues from speech therapists, they talk about the importance to include a speech therapist on the multidisciplinary team to assess patients that have sleep disorder breathings, and the importance that is to recognize that work of the speech therapists on all this process. And continue on the revision of the literature. So this is a very good article. It was published in 2023. It's a systematic review of 140 papers out of 1,700. Well, a lot of articles here, so it's huge evidence. And according to the founds that oral myofunctional therapy can improve the strength, the shape, and the function of the oral and facial muscles, as well have a positive impact on children who are growing. So re-education, stabilize, I would say, balance the treatments, give them a better prediction of the treatment and the follow-ups. It's very, very important. And the systematic review revealed that the oral myofunctional therapy improved not only the function, the morphology, and the craniofacial surface of these children with OSA, but also becomes more significant as the direction of the intervention increase and the compliance improves. So that's also important to remind. And another very interesting article, it was a study of only 14 children, but imagine that the ones that were submitted to adenotonsillectomy and had myofunctional therapy combined with this therapy that reduced and were cured from the apnea-hypopnea index, and the other ones who did not perform myofunctional therapy, after 4 years, they developed obstructive sleep apnea. So it's very important to work to do these exercises in order to balance the function, in order to properly have a positive outcome on the therapies. And another systematic review of 124 articles. Here, the results, we could evaluate not only the decrease of the apnea-hypopnea index, but also the improvement of the oxygen desaturation index. And major importance also, daytime somnolence and night snoring. Even though daytime somnolence in children, it's not, as you know, a very common sign, more for adolescents, not for toddlers or infants, but even though for the adults, it's very important to reduce daytime somnolence. It's one of the criteria of success of the therapies. Another very good article from a group of Italy, led by Maria Piaviglia. I think that some of you know her. And this article, it was an evaluation of 54 children with an average of 7.5 years old. And Maria Pila, she evaluate the muscles with the EOP, which is the instrument that can give you the intensity of the work of the muscles and the strength of the muscles. And after the exercise protocol and also evaluating with the nocturnal pulse oximetry, she could reach that they had not only good response on the results of the oximeter, but also they improved the oral breathing pattern, the muscle tones of the labial muscles, the orbicolor of the muscles, and also the tongue posture and the oxygen, the saturation index. It's also improved on this. So it's very important also to remind. And we can continue. And the literature, they also are in consonance, and they all mention the reduction of the daytime sleepiness after the evaluating or re-evaluating the groups, not only the controls, but also the ones that are in the exercise therapy. So the reduction of the daytime sleepiness, the improvement of the snore index, and also the hypoxic burden. It's also improved. So better oxygen saturation under 19% time. So it's very important also to mention this. And the major thing from this article, I would say that it was the hypothesis that they launched that oropharyngeal exercise and mobilization exercise of the inspiratory muscles could be improved the dynamics during sleep and reduce snoring. And this is something to consider. The group of Venkatas, my friend Venkata from Paris, also published in 2021, narrative review, but a very written narrative review. And he concludes that all the studies demonstrate the reduction of snoring, the apnea and hypopnea index also reduce, the daytime sleepiness improve, and also improve the oxygen saturation and the sleep quality. So they conclude that therapy could help to reposition tongue, improve the nasal breathing, increase the muscles tone in pediatric and adult patients. And the importance that it is for oral myofunctional therapy to prevent residual OSA in children. And this is very important. And we already saw that on the anterior article, the ones that the group performed the exercises on after the surgery of removing the adenoids and the tonsils. The group that did not had myofunctional therapy after 4 years, it has residual obstructive sleep apnea. So again, it's nothing that we cannot do or recommend, or at least awareness the parents and give them the tools so they can also at home can perform all the exercises. What I'm going to share with you is the anamnesis in the myofunctional therapy. So this is a very long clinical history. So one part of this that I'm going to share is done by me on my appointment. The other part, it's my speech therapist or the speech therapist that collaborates at the clinic that do, because otherwise it will be a very long appointment and we will have the fatigue of the parents and the fatigue of the children, and we need their collaboration, as you know, in order to perform a very well anamnesis or history, clinical history. So of course, as we all start what you bring you here. So the chief complaints, the treatments that this child had before, if they were succeeded or not succeeded, how was the pregnancy? So it's very important also to know this. all the diseases, so all the past familiar history or the children history, it's also very important. The food and the diet, what were the lifestyle during all this development of these children, the introducing of the solids, and if he continues to have liquids only, or if it was okay when the transition from the liquids to the solids occur. If there are any parafunctional habits, for instance, the pacifier or even the thumb section. So it's very important also to know that. How is the speech and psychomotricity development? Very important also to know if there are any psychosocial factors related, if the children is in school, if he has any difficulty to adapt or not, if there is a good relationship between the professor and also with the colleagues and also with the staff of the school. So it's very important also for us. And I'm always very observative on the first appointment, not only in the cabinet, but also when they are in the waiting room. I like to observe them and see how they behave and see the posture that they have, not only the child, but also the parents. It's very important because if we are talking about myofunctional therapy prescription for a child, we will need the parents or the family cooperation in order to assist the prescription. This is not a validate questionnaire, but it's a questionnaire that I like to use that I ask 4 or 5 questions in 3 parts of the day-night of the patient. It's the 3 Gs questionnaire. It's go to bed moment, it's the go to sleep moment, and the get up moment. So during these 3 moments, I ask when they go to bed, what time they go to bed, what they do 1 hour going to bed, if they play with the mobile, the phone, the computer, tablets, whatever. So I like to know that. Also to evaluate the habits, the sleep hygiene habits. If the room has a present light, what color is the light, what time usually the child have dinner. It's also very important for me to know. And then in the go to sleep moment, it's how long does the child takes to fall asleep, how are the sleep, so if he's calm or agitated, if the child talks or walk during the sleep, if there is any respiratory events, breathing or whatever noises while the child is asleep, and if the child breathes, is a mouth breather or not. Some of the parents or some of the patients, they don't know how to respond. So my next question is, how is your pillow in the morning? So if it is wet or not. So probably he's a mouth breather. And then the get up moment. So I like to know what time does the child get up also, and not only during the weeks, but also during the weekends. And this is very important to ask because you will have an idea if the schedule of going to bed and wake up are the same, or sometimes they are not the same. They sleep more during the weekends, and this might mean that they are in sleep deprivation. So yeah, it's very good to ask those. And if they wake up with or without the help of the alarm clock, it's also a very important question to do, because this is also the idea if they have good schedules or not. How is the mood in the morning? Also very important to know if there is a breakfast or not, because usually mouth breathers and snorers and OSA patients, they don't have so much hungry in the morning when they wake up, so they avoid and they skip the breakfast. And what time starts school? So very important also to know that, because the majority of the children right now, they don't have good schedules, they don't have good sleep habits, and they don't like to wake up really early to go to school, and they don't have a good performance at school, I think, because of that. Oh, sorry, I skipped 1 slide. So I continue also the observations. So some of those are mainly done by the speech therapists that work with us and collaborate with us. So There's an exam and observation of the lips, of the tongue. We do the tongue tie score, like I showed you in the slides, in the previous slides. We also evaluate the palate and the relationship between tonsils, uvula, tongue. We use, of course, Mallampati score. For the tonsils, we use Broadley score. We also see the cheeks and the internal surface, if they are bite marks. Perhaps it could have a bruxism or so we like to see all of those. Also, the relationship between the upper jaw and the lower jaw, the dentition, the conditions of the overall oral health, periodontal parts, teeth conditions, oral hygiene. We also look at the nose. It's very important to see if there is any septum deviation. They are hypertrophy of the turbines. How are the adenoids in the nostrils? Are symmetric or not? For the adenoids, of course, we cannot see directly, but if you have a CBCT or if you have a teleradiography, you can look at it, or any kind of TC or ERMI, you can see the adenoids. For the respiratory function, so we use the test Glatzel, which is a mirror that I will show you in a few slides ahead, that you can see the permeability of the nose, if he breathes well or not. And again, we continue with the posture, the vertical posture. We also do a little test with solid food to test how do they chew, how do they cut with the anterior or with the posterior teeth, the amount of food they put in the mouth. And then the swallow part, how do they swallow, if there is any compensations of the muscles of the neck or on the head, because sometimes they have those compensations to help them swallow. Not only the solids food, but also the liquids. They do a lot of facial mimics as well, if they use not the proper muscles. So we need to sometimes to record the child in order to do a proper evaluation. And of course, the last but not least, the speech articulation. So repetitive speech exercise in order for us to see if there is any problem on the articulation of the words and on a dictation also. So it's a long evaluation, but you need to do it. This is also one of the tongue tie classifications. So you can use one of these gouge, and you can evaluate the size and the size of the tongue tie. And according to this, you can have a proper idea if it is normal, mild, moderate, or severe tongue tie, and then you can consider surgery or not. If you have doubts, start with myofunctional therapy, and if you don't, you do the surgery. So Mallampati, I think that you all know now the Mallampati, also the Broadis, the Glatzel test. So I use the Miro. If you have the good ones, they have those graduation that you can see the amplitude of the respiration. If not, you just use a regular Miro. Or you can use the Rosenthal test. There are 3 basic rules. So awareness, proprioception, and verification of the nose before you start to do the exercise. The massage before you also start to do the myofunctional therapy. It's also very important to have the very good nose, permeable, cleaning nose. So and start with all of those 3 parts. There's no contraindications or side effects, maybe some limitations, I would say. The most common are the age of the patient, the motivation of the patient, and also the family cooperation. They are some things that some other disharmonies that you could and should have in consideration. So dental skeletal disharmonies like palatal fissure, neuromuscular tonal syndromes, some cognitive or intellectual disorders, also to be the parafunction habits. So if there are a habit of pacifier or thumb suction, so maybe you will have some problems and have good outcomes, but well, it's what it is, and you need to evaluate. Or if the child has a respiratory chronic disease like asthma or bronchitis. So yeah, again. So rules, practice at the same time. Perform the exercise in front of the mirror. The children should do exercise with parents' help, and they clean and wash the nose before perform all the exercises. Some of the exercises that are prescribed, and we use a lot of them, so it's the respiratory exercises. Inspiration by the nose, expiration by the mouth. You can use candles, you can use the blow. We can do the blow with the windmill or drink through the straw, and then you can expire through the straw. Also the blue balloons or swimming shoe, and do the balloons with the swimming shoe. For the exercise protocol for snoring, so if you want to work the genial glossus, if you remember, I focus a lot the genial glossus. So if you want to work the protrusion of the tongue, you have a lot of exercises, and this is like going to the gym. So you need to practice 3 series of exercises 3 times per day, 10 exercises, then you rest. So it's again, you have to be very aware again of the fibers, the color of the fibers means the type of the fibers in order to not have fatigue. Otherwise, you will not have adherence or compliance of your patients to the prescription that you are done. So if you want to work the buccinators and the orbiculars, you can use the tongue depressor, and this is a very nice exercise. Or if you don't have those, you can use a little spoon of the coffees, or even the ice cream spoons. Also, you can use those. For the palate muscles exercise, so the best exercise is the sing. If you don't like to sing, you just have to repeat the ha intermittently during 10 times for 2 weeks, and doing these exercises, performing these exercises, and you will work the tensor palatini, the levator palatini, the uvula, the palatoglossus, and the palatoglossus arch. And if you recall one of the first slides on my presentation, the one who has the arrows with different colors, that was one of the exercises responsible for the advancement and for the lateral open of the upper airway. So you are working a lot of muscles. There are tools, and I like to use those slides and those photos that I took. Some of them are from my master science courses when I did the courses, and we used to play saying that ones who are on the left are the domestic tools, the ones who are on the blue pocket are the fancy ones. But basically, you can use a lot of tools, domestic ones, to help you to perform the exercise and to prescribe the exercise. Also for the blow tools, so you can use like candles, simple candles, but also you can use a lot of those exercises to practice. Or the flow ball, it's also very nice, and you can increase the difficulty of the exercise by monitoring the time that the ball is out of the basket. So it's also very nice to do, and children, they love it a lot. For the stringing tools, so you have those rubber and silicone appliance. You can work the masseters and the temporalis with this. Also, mandibular asymmetric mandibular deviation. For the cross bites, who are functional cross bites, they are very good to work and to solve that. So as you know, you should not correct a cross bite if it is not skeletal, starting with a rapid expander. So you need first to take care of the position. So you need to work with those tools in order to put the mandible on the right spot. These chewing necklace, I like them a lot because some of the children have some perfunctional habits, and some of the children, it's one of the signs, I would say, or the alert signs of perhaps we have a bruxism patient, children who brux. Usually during the day, they like to bite and chewing the pencils, the fingers, etc. So if you prescribe one of those, and every time they are stressed, they can bite this chewy necklace. Also to work the mimic facial muscles. So you can use a lot of tools to work the lip tones, and also to work not only the orbicular but also the buccinator and the upper lip elevator and the mentalis muscles as well. This is a domestic, I would say, I like to call it a domestic app. It's not, it's just a notebook where you can draw the exercise. It's a motivation tool. And you can draw the exercise in order to help the children and the parents to perform the exercise at home. It also helps to personalize the exercise as well. But you can use, there are some digital tool apps in the market right now. This one, it's 100% in Portuguese. It calls Happy's, and there's a lot of exercise here on this tool, and also with different difficulties and levels, and it's very motivational for the children to use. And talking about exercise, myofunctional exercise and treatment, and also I have to mention the tools for the adults, and I have to mention a tool that was developed by a colleague here in Spain, Carlos O'Connor. The Hairway Gym is a validated tool. You can recommend it. This is in English. You can recommend this to the patients, and it is validated with a high evidence. And with literature that has been publishing by the group of Carlos, and he do this very well. It's a very good tool. One of the articles that he published, you can see the difference with 3 months before and after using the Hairway Gym, and the evaluation of the UBOPI. So you can see that is a very good results for the muscles. Kinesiotherapy, I have to mention this. So this is also fashionable. We can see in a lot of non-sets, in a lot of facial media, people using this all day, playing the sports with the myotapes. But you need to be careful, because you need to evaluate the nose and see if there is any difficulties or not to breathe by the nose. Then you be very careful prescribing this exercise, these myotape, sorry. But you can use it as a combined therapy, crossing with a myofunctional therapy. So I have one case. This was a child with 6 years old. He was at my clinic after the pandemic. He was sent by a colleague with a crossbite, just for me to evaluate if he had any problem with his slip. I evaluate him, so he has the crossbite. I did a cephalometric analysis, but I'm not going to show that. It's not the object of this clinical study. But during my evaluation, I asked him to open the mouth and try to reach with the tip of the tongue the palate, and he couldn't move the tongue. It was like that. So he had also other signs of bruxism, because he had all the tip of the fingers and the nails were bleeding. And also, when I manipulated the mandible, I saw that the crossbite was a functional crossbite, even though there was no discussion on this. He needed orthodontic treatment or orthopedic functional of the jaws treatment. But you could see that he has a polysomnography with a positive result and diagnosed for obstructive sleep apnea, even though it was a mild one, but there is the results, also with some resistance of the upper airway. So we started with myofunctional therapy during 9 months, and we did some also combined with posture exercise that were indicated by the physiotherapists that work with us, and you can see the improvements. We had a lot of improvements on the bite, on the occlusion, even though he continues to need orthodontic treatment. But we had a huge improvement on the posture of the tongue, on the mobility of the tongue. There was no more the parafunctional OVID to shoe and to shoe the tip of the fingers and the nails. And we did reduce the apnea-hypopnea index with no criteria of classification of apnea, hypopnea index. And this is only done with myofunctional therapy and posture exercise. And the second case, it's an adult. It was a combined therapy, and I'm almost finished the cases. So it's adult cases. It was a case that were prescribed. We prescribe a mandibular advanced device, and we combine it with myofunctional therapy. So she had all the diurnal signs and symptoms, also night symptoms, and all other type of symptoms also. We collaborate on I have the lucky to collaborate on a multidisciplinary sleep team. So our ENT also evaluate this patient. She had rhinosinusitis, and she went under prescription to control all that part. We performed a polysomnography, a type 1 polysomnography. It was a mild cases, but with a lot of signs and symptoms. Sometimes these kind of patients, they situate or they are classified as a cluster of the obstructive sleep apnea pattern, classic pattern. So we often take more attention of the signs and symptoms, and we give more importance to that, or equal importance to that, as the polysomnography. So we started with all the criterias and all the protocol in order to perform the mandibular advanced device. So we took the bite construction, the therapy bite construction, with the George gauge, with the protrusion, and the range of motion, everything like by the book. She was wearing this mandibular advanced device, but also at the same time performing myofunctional therapy. What we could have immediately after 8 weeks, it was that no more snore was reported by her husband, or apnea episodes, no somnolochia, no excessive transpiration, and no nightmares, and no somnolence, diurnal somnolence. And we were talking about a young female who was doing her PhD with a huge difficulties because she was always sleeping. And this was very important to her. Even though we did the 3Gs questionnaire just in order to see how was her behavior and if we could adjust any of the hygiene sleep rules that perhaps she was not doing so well, so she needs some help on that. So, and we prescribe also a new polysomnography using the mandibular advanced device. And I will show the results on the next slide. But before that, this is the results after 1 year follow-up from the left to the right. So on the left, on the very left, the initial presentations, on the middle, 6 months after myofunctional therapy, and on the right, after 9 months of myofunctional therapy. This is very subjective. I know that you are thinking, oh, but she can, manipulate the position of the tongue. Yes, it's true, but at the same time, it's the huge difference that you can see. And it's not just that, because we did perform the polysomnographies at 6 months and 1 year. So we know that what happened. So if you compare the first polysomnography and 8 weeks after with mandibular advanced device, you see some improvements, yes. But after that, we just add and we just reinforce the use of myofunctional therapy. And by that, 1 year after, you have a lot of difference. Yes, you have a little difference on RAM, because RAM sometimes is difficult to control, but if you go and see the baseline of the apnea-hypopnea index, you have no criteria of classification at all of apnea-hypopnea disorder. If you look on the supine, you don't have criteria to diagnose a posture, positional apnea, and also you improve a lot the resistance of the upper airway. We improve the oxygen saturation, the oxygen nadir also improve. And well, not so improvements on the periodic limb movements, because that could be related to metabolic issues or iron deficiency, as I think you all know. So this case, it's published and was published by my colleagues and I. So if you want to take a look on the article, it was published on the beginning of the year at the Journal of Dental Sleep Medicine. And so my take-home message is that I do believe in myofunctional therapy, of course, otherwise I will not be here talking about it. But myofunctional therapy on rehabilitation on both pediatric and adult snoring and OSA are so fundamental for muscles re-education, tonus, regarding the upper airway, the balance of the orofacial neuromuscle structures, and in coordination or as a solo and very well identified patients can improve mastication, swallow, and breathing, and indirectly contributes for a better quality of life. And of course, myofunctional therapists should be part of the multidisciplinary teams in order to give more individualized, personalized, and we are talking about precision medicine, so we need all be part of the group. So thank you so much for the time, and I'm very happy to answer your questions. And you have here my contact if you want me contact after this. So thank you.
Yay!
Muito obrigada.
Muito obrigada. Very,
Muito obrigada.
very good. I know, isn't it crazy? I was interviewing someone from Argentina the other day, and I'm from South Brazil, really close to Argentina, and we're both speaking English. And now you're in Portugal. I'm also Brazilian, but I'm in the US. What a wonderful presentation.
Thank you so much.
Thorough. I know that area circle members are going to be freaking out when the rest of the crowd listens to this. If you don't mind and sharing your screen, I have
of course
few
not.
questions.
Of course.
To ask before we go. And you guys, if you have any questions, the ones that are here live, you're welcome to put in the chat box.
Yeah, of course.
How do oropharyngeal exercises compare in effectiveness to other non-invasive treatments for OSA, such as CPAP or mandibular advancement devices?
If you practice as a solo, you need to identify very well your patients, not only the structures per se, but also the capacity of the patients to perform the exercise, the motivation, like I mentioned. So there's no side effects on that, but there are some limitations. If you are talking about a young child, you need also to motivate the parents, because this is not a thing for a child to do alone. So we need the parents by our side, and we need to be in front of a mirror at the same time. So you need to have habits. You need to educate all the family. Then if you are talking about a teenager, that's more difficult. But if you could find out some nice exercise that then can motivate him, maybe for teenagers, I will recommend the Airway Gym. So it's very good. Or any app that they can, download on the mobile, so you can have also those adherence. And in order for that, it's not the same. We are talking about adherence, it's not the same as efficacy or effectiveness. But if we talk about effectiveness, you need adherence in order to have good results. And what I can, it's what we do is that we follow up on a very strict protocol, all the patients. We know that we are going to only see results 6 months from the first appointment, but we follow the patients every month. And if we could, and this also depends the financial situation of the families, the ideal is to see the patient, if we are talking about the infants and the toddlers, every week or twice a week. But on adults, sometimes this is also difficult because of the jobs and so on and so on. So every month, or at least every 3 months, and then at 6 months, you will control the exercise. And there are a lot of tools that you can use before you perform a second polysomnography. And when I say tools, it's tools to evaluate the strength of the muscles. And you can use a lot of mini alters to see if the tongue has strength, to put some weight on that, or the IOP, which is the instrument that can measure the muscle fibers. So you can use a lot of those. Yeah. But it's like select the best patient, perform, and you will start also to have more confidence in prescribe because you start to see the results.
Is it 100% the importance of having a whole team?
Yeah.
It's not only about myofunctional therapy. It's not only about, but having an ENT, so you understand what they are seeing, what they recommend, and having an orthodontist to see what they recommend, what they are seeing that maybe you can't, and you three working together, amongst other professionals that may be involved is so important. Are there any challenges in patient adherence to oropharyngeal exercises regimens, and how can clinicians improve compliance?
I think it's not too high. It's again, it going on the same direction that I was talking about before. It's not give a large schedule between appointments. So keep it straight, keep it like protocol every 1 month, control the exercise and change the exercise. This is like going to the gym. If you are going to the gym and if you are continually doing the same exercise, imagine to work the biceps and using the halters to work the biceps, you will be fatigued of the exercise of the gym and everybody around you, and you will never go back to the gym. So you need to change the tools and you need to change the exercise. And the thing is that you can work the same muscles with different tools and different exercise. So again, you need to know first anatomy, you need to know the fibers, you need to know which muscle do you want to work, and then which are the exercises that are more recommended for that muscle. And you choose like 3 exercises and you change it 3 exercises every 2 weeks. That's the way you will have more adherence to the exercise and control the exercise. You can use a lot of things. You can ask your staff to call the patients to remind that are you doing the exercise? Do a little survey. Are you doing the exercise? What time are you doing the exercise? And week by week, you can guide your patient and in order to keep the adherence of the therapy.
100%, yes. Do you think that patients that choose to go with a mandibular advancement device can still benefit from myofunctional therapy? And especially in the United States, there are so many dentists right now going into dental sleep and they're prescribing those mandibular advancement devices, but there's not the knowledge yet of maybe there's something else that can be also, helpful for this patient. Do you think there is benefit to do both together is the first part of the question. And the second part, how can we encourage these professionals to encourage their patients or educate these professionals to encourage their patients to also seek myofunctional therapy as part of their treatment?
Yeah, good question. So for the first and second, part of my protocol is to give my patients a morning occlusal guide in order for they to chew that rubber dam silicone. I have a patient who baptized those as a chiclet silicone because she looked at, this look like a chiclet silicone. Yeah, you can, and I do that. So my protocol is with the mandibular advanced device, and you have a lot of positive things using the myofunctional therapy. First, will reduce the side effects of tenderness and pain of the muscles. Also, the strength that you are adding to the joint, so that avoids the pain of the joint. And but you have to do differently. So what I do is that with that silicone chiclet, I say to my patients, in the evening before you put your mandibular advanced device, you are going to just with the incisors to chew the silicone, because that you are activating the movement and the mandible to go forward. It's what you want, okay? But in the morning, when you remove the mandibular advanced device, you need to relax the muscles. because you need to explain this to your patients. Advancing the mandible, you are not doing you are not relaxing your muscles, because it's what people do when they go to the gym. They stretch, they are elongating the muscles, they stretch, and they think they are doing the same here. So that's not the same. When you advance, you are contracting the muscles. In the morning, you want to relax, and the only way to relax is to chew on the molars, and you have to chew the same times that you chew on the right, chewing on the right, on the left. But in the molars, you put the morning occlusal guide or the silicone chiclet, whatever, between the molars, and you chew there. Because if you are going to continue to chew with the incisors, you are going continue to protrude the mandible. It's not what we want. With this, I can control side effects, occlusion changes.
Yes.
Those things that I'm talking about, the tenderness of the muscles, the joint. Of course, if this appears and continues, you need to look other things, okay? It might be that you are advancing too much. It might be that you did not control the vertical dimension. So it's a lot of meanings, but with this, we have good results. And actually, if you go for the article of the journal Dental Sleep Medicine with these clinical cases, the adult one, you will see that one of the reasons that we had the myofunctional therapy as a combined therapy, it was that this patient had some crepitation on the temporomandibular joint, and we could control all of that in order for not have more pain and on that.
All right. We have a few questions coming in. I'm gonna do
Okay.
my routine is starting right now. I have to run, y'all.
Okay.
We have, how do you prevent wiggling of front teeth after wearing a mandibular advancement device?
Sorry, I didn't catch the question.
How do you prevent wiggling of the front teeth after wearing the mandibular advancement device? So people are having the front teeth be a little loose.
That is because you need to check if you are advancing too much. You need to check what type of titration do you, the protocol of titration also, the relationship between the upper and the lower tray. If the connectors are anterior, you will have more pain and discomfort on the incisors. If they are lateral, maybe you are advancing too much. And also check the vertical dimension. So perhaps it's a little bit high and you need to decrease.
Are there any exercises to help lift a long, soft palate?
Well, singing, it's one of them. Singing is a good exercise. One of those that are recommended are the ones that I show, the ones that you can say ha 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 ha. So you have to practice karaoke also.
Yeah.
And you also have those now the name is escaping me, Renata, the ones, the tool that the Australians use to play the didgeridoo.
Didgeridoo.
Yeah.
You get you Portuguese speaking, try to say that. It's not very
good. Didgeridoo. Yeah.
Yeah, there's many, but it's so funny that whenever I first got into this field, I never understood the long, soft palate. And I actually started calling it the low, soft palate, because a lot of times it's because the maxilla is too narrow. And whenever you expand the maxilla, it lifts up. It's not that it's long, it's just low because of the position of the maxilla. It did not expand plenty. So if they cannot do palatal expansion, and after they've done myofunctional therapy, if it's still super low, then going to consult with an ENT surgeon, a sleep surgeon who can take a look. They have so many beautiful techniques nowadays. The barbed wire technique, they no longer have to, cut the tissue. They can just lift. Some pharyngoplasty.
But do that always with a protocol with myofunctional therapy. I would recommend that. Always, before and after every intervention, even with mandibular advanced device. Even though mandibular advanced device can give you an indirect contraction of the muscles, because you will see some differences before and after. But if you add myofunctional therapy, you will control a lot of the balance of the tonus, and also side effects, occlusal changes, everything. So it's nice.
Perfect. And do you ask patients to continue any particular exercises to maintain what was gained through an MFT program?
Yeah, the thing is that if you believe in neuroscience, you know that after 21 days, your brain will continue somehow one part of the things that you learn. So yes, actually, when you are on dental sleep field, or I would like to call it as a dentist that I'm on sleep medicine field as a dentist. So, and again, for the myofunctional therapists also. But if you are on the sleep field, you need to do follow-up appointments to your patient, and you need to check, and you need to perform polysomnographies each year at least. So with that, you can control if they are having good results or no. Even if you do a polysomnography type 1, you can see if they are cheating, because you cannot you can have the results that there are no criteria for apnea index diagnosed, but if they have upper airway resistance syndrome, is because they didn't work very well the exercises, and the tonus is fragile, and you see that. So yeah.
100%. It also has to do with your diet. You know, what types of
And
foods you're
yeah, of course,
eating
and then lifestyle. It's a lifestyle change.
to make sure that it's going
I
to
have
support that muscle health.
Yeah, yes, I agree 100%. I have a patient that I'm now preparing the clinical cases. It's an adult. I only prescribe lifestyle changes, myofunctional therapy, exercise, and diet. He was as a young man, and it's unbelievable. He has no criteria for apnea, and he has no mandibular advanced device and no CPAP. So, as I said, if you want to continue like that, so you need to continue to do the exercise. You need to recall the exercise that you learn with the speech therapist, and apply them every time that you are eating, every time that you are drinking, every time that you are on your job. Just have a tongue pressure or some stick of the ice cream or so, and just put on the lips and practice. So simple things that you can continue.
100%. Oh my goodness. I'm just gonna really quickly. We have an incredible lecture in MyoCircle, which is our advanced myofunctional therapy course on Airway Circle by it's a lecture on sleep by Marielle Bussi. And she talks specifically about this, Judy, which exercise she recommends after you done. It was a question that I asked her specifically, and she tells me the exercise there. So if you haven't taken a myofunctional therapy course yet, or if you're a physician who just wants to learn more, MyoCircle is okay. Otherwise, you can start with Foundations, our course.
Let me just invite who is here. I will be in Singapore in 1 week, and I will lecture exactly about this thematic that I was here sharing. So the ones who wants to join the symposium, they are very welcome to do so.
We do have people here that are going to be in Singapore, and I might go crazy unless I can just take a plane out there with you guys. I'm major FOMO right now. And Renata, what is the name of the procedure again for lifting the soft palate? It's called pharyngoplasty. There's
pharyngoplasty.
Several different ones they can do. I've watched a few barbed wire pharyngoplasty done in Italy.
There are also some treatments right now that are photo biomodulation of the soft tissues. There are some colleagues, there are a very strong group here from Madrid, Pedro Mayoral. He's working with Alberta and the colleagues from there on research, and they are having, some good results.
That is fantastic. Well, thank you so much. This has been an incredible
time. It was a pleasure.
And I appreciate you guys staying late. I will see you guys next week. Thank you. Have a wonderful
Bye-bye. Bye-bye.
Bye.
Thank you. Thank you so much.